Good afternoon, everyone. My name is Yuan. I'm assistant professor at the Yale School of Medicine. And sorry for being delayed. Should be supposed to be my first presentation here to give a very overview on the global perspective on obesity. I was trained as an epidemiologist, so I was providing some epidemic perspective on obesity. I'm also associate editor in JACC, so we welcome your submission to JACC. And thank you, Dr. Kramer, for your nice presentation. So to start with, we want to understand the importance of obesity as a global health crisis. This is from the Global Burden of Disease Project, looking at the trends of overweight and obesity in the last 30 years. The panel on the left-hand side is showing using BMI greater than 25 to define overweight and obesity, and the panel on the left-hand side is looking at BMI greater than 30 for obesity. And we can see for both metrics, there has been an increasing trend over time over the last 30 years. And it's not only for the global level. The dotted line actually show that for developed country, for both men and women, there has consistently increased and has the highest increase across different countries. But these trends are not just limited to developed countries. Developing countries also seen consistent trend. What is the scope and scale of obesity epidemic? This is from another large collaboration, the NCD risk factor collaboration. This graph actually shows you individual countries, what's the prevalence of each BMI categories between 1990 and 2022. And just by looking at the color scale, you can see from the yellow color, pink color, and red color, these indicate overweight and obesity. So just a snapshot, you can see the area for different color change over time. The area with yellow and red color increase. So US here, clearly, this is for women, the prevalence of overweight and obesity, represented by the area in the yellow and orange and red color increase. China is here. Even though the increase is relatively small, but we can still, there's increase over time. Similarly for men, we can see similar increase here. This is US and China. And this is another graph to look at the change in age standardized prevalence of obesity. So just put it in another way. If the change is greater than 0, that means there's an increase in prevalence. So this is looking at the change. On the left-hand side is women, on the right-hand side is men. So we can see there is some disparity across different countries and regions across the world. But almost every single country, except maybe Middle East, like somewhere there, in women there has been a decrease or smaller increase. Other than that, other country, it has consistently observed an increase in overweight and obesity. In the US, the increase may be like 20 to 30%. So in China, there's also increase, maybe around 10%, just by the color. So just to put it into number, it is estimated the number of people around the world that will be living in obesity in 2035 is 1.9 billion. So it's greater than the total number of people in China. It's a huge market. The estimated global economic impact of overweight and obesity in 2025 is $4.32 trillion. And the childhood obesity is expected to increase by 100% between 2020 and 2035 within the 15 period of time. And it's estimated 1 in 4 people living in the US have obesity by 2025. Is really a huge market and a huge burden, not just economically, but also disease burden that poses on the society. So obesity have a large impact on cardiometabolic health, just as Dr. Kramer already pointed out, but this is from a population level. Looking at prospective study collaboration is pulling 57 individual prospective study together, published in Lancet, in 29. So this is looking at the relationship between BMI and blood pressure. In the first panel, we see there's a linear relationship there, meaning that as BMI increase, your blood pressure also increase. And the left-hand side, panel B, showing the relationship between obesity, BMI, and blood cholesterol. And there's also a positive association between those metrics. So obesity leads to hypertension, dyslipidemia, and diabetes. This is another study recently published in Lancet Public Health looking at the risk of cardiometabolic multimorbidity associated with obesity. What to define here for incidence of cardiometabolic multimorbidity is at least 2 from type 2 diabetes, coronary heart disease, and stroke. And this is showing the hazard ratio for BMI. We can see that as BMI increase, the hazard ratio substantially increase. For those with extremely obese with BMI greater than 35, there's 15-fold. The odds ratio is 15.1, meaning they have 15-fold increased risk compared to those with normal weights for the cardiometabolic multimorbidity. Obesity also increased the risk of cardiovascular events. This is another very large study from the Emerging Risk Factor Collaboration, combining individual level data from 58 prospective cohort study. And it shows that even adjusted for all these demographic behavior risk factor, there's still a positive relationship between BMI and coronary heart disease on the top row and ischemic stroke on the bottom row. Clearly, obesity is a risk factor for the leading cause of death, which is cardiovascular disease in the world. What is the underlying cause of obesity pandemic? At the population level, I think the fundamental problem is there's an imbalance between the energy intake and energy expenditure. So this is a graph giving you a framework to looking at there's a balance between the food intake, the metabolic energy expenditure, and the physical activity. For example, overeating will increase your energy intake, but if you don't have enough energy expenditure or physical activity, like physical inactivity, you don't have enough energy out. So the balance, the tip will drop. That means you have more energy intake that leads to obesity. This is another graph showing food availability in the US from the last century, the whole 100 years. We can see 2 phases. Actually, the first phases is between 1910 to 1960. It's called the pool phases, where there's a reduced energy expenditure during the energy intake. So people, due to limited food availability, they may be starving there. There's less likelihood for getting overweight and obese. But starting from 1960, they're entering into another phase called the push phase. So there's more food leading to more energy intake during the energy expenditure. So as we've seen in the previous slide, the balance changed and started from the CDC statistic. We see the prevalence of obesity starting from 1960 in the US continuously increase, more than double. Now the prevalence of obesity is more than double in the US compared to 40 or 50 years ago. So just to put them in a framework, at the population level, this is a framework to summarize what is the obesity prevalence, the obesity determinants and solution. The determinants may be from different domains: environmental, behavioral, and physiological. There are systematic drivers. Policy, economic system enable promoting high growth and consumption. Environmental factors, the food supply and marketing environment will also promote high energy intake. In the example of China, we know there's a huge modernization and urbanization after the open door policy after 1979. So there's more Western food intake. There's also change in the behavioral pattern, like physical activity is less likely to have physical activity and more likely to have sedentary behavior, and finally leading to energy imbalance. So because the determinant is in the multi-domain and multiple level, that means our solution also need to be diverse. For example, policy intervention may be helpful to address those systematic and environmental drivers. And for behavior driver, there may be needed for health promotion programs, food marketing, social marketing program. And for energy imbalance, we may need innovative drugs and surgery bariatric surgery, for example, to deal with that imbalance. So really highlighting this framework, really highlighting there's a demand for diverse intervention to address the increasing global crisis in obesity. So what are the effects of the current non-pharmacological and community interventions? This is a meta-analysis to compare the cost effectiveness for selected intervention in Australia. We can see for non-pharmacological community intervention, most of them are focused on lifestyle intervention, such as diet, exercise. Community-based programs actually show mixed effectiveness in sustained long-term weight loss. It's not very effective in reduced weight, and especially in the long term, if you want to maintain those reduction over time, that has been difficult. This is another meta-analysis to combine different trials, looking at behavior and lifestyle study to look at the weight change in 12 months. There's lots of number here. I don't expect you to see all this number in detail, but just focus on the pool result at the very end. Pulling them together, it shows the mean difference in weight loss is minus 1.56. It's significant, but it's small. So the behavior intervention that deal with both diet and physical activity shows significant but small benefits on weight loss maintenance. How about pharmacological treatment? This is a recent meta-analysis published in Lancet by our Chinese authors. We can see that actually traditional pharmacological treatment, if you look at the percentage of weight change, is very limited, is around 5%. Except for the first one. And GLP-1 RA, as we showed, semaglutide may have a bigger change, like minus 11% reduction in weight change, but those older generation of GLP-1 RA shows around less than 5% weight reduction. So traditional pharmacological treatment achieve moderate weight loss. That gives us the possibility to look at the more novel therapeutic innovation in obesity management. And it actually shows a big promise. As Dr. Kramer already mentioned, there are drugs targeting multiple pathways, such as the GLP-1 receptor agonist. And one of the key trials is the STEP trial. There's maybe overlapping material already talked about, but just to remind you, the STEP trial is looking at semaglutide injection, 2.5 milligram and once per week, and we're looking at up to 68 weeks. You can see that it's about 16% weight reduction there, much more than the previous traditional pharmacological treatment that I showed on your previous slide. So at 68 weeks, there are about 86% people achieve more than 5% weight reduction. And 69%, almost 70% of the people in the trial achieve more than 10% reduction. It's really impressive, way more than what we have seen for lifestyle intervention and all those traditional pharmacological intervention. Also, the SAMAN trial looking at tirzepatide, Dr. Kramer already covered that, different dose of tirzepatide. By 72 weeks, we can see 22.5% of weight reduction for some tirzepatide 10 milligram, 15 milligram, and 21% for 10 milligram. And even for 5 milligram, it's 16% reduction. Really impressive here, compared to only 3.1% on the placebo group. And the SELECT trial, this is showing what is promising here is that these drugs not only just reduce weight, but it also reduce cardiovascular risk. This is the SELECT trial to focus on people without diabetes. And looking at, this is the time to event showing the primary cardiovascular endpoint. So this a composite cardiovascular endpoint combining death from cardiovascular disease and non-fatal coronary heart disease and non-fatal stroke. We can see that the hazard ratio comparing semaglutide with placebo is 0.8, meaning that there is about 20% risk reduction in cardiovascular events. This really opening up a big market or promise for these drugs not only used as a chronic weight management, but also as a drug for cardiovascular risk reduction. So just to put this into summary, and what is the takeaway here? My presentation just to give you an overview in the big picture. So we know about the global prevalence and impact. Obesity are rising worldwide, affecting millions across all regions and demographics. Secondly, there are immense economic impact of obesity, impacting economic productivity substantially. And we also have a brief review for the current approach. Traditional lifestyle intervention and medication have shown limited success in achieving sustained weight loss and addressing obesity at scale. And that leads to looking at novel therapy to look at the potential of this therapy, such as incretin therapy that offer promising results, potentially revolutionize obesity management. So that will connect to the next presentation from my colleague Erica Spass, who can give more in-depth detail on how incretin-based treatment can affect different outcomes. Thank you very much.